Hey everyone, it's time for our compilation video, and this week we have been discussing low sex drive, different kind of things that cause that, ways to treat it, and how it affects specific conditions. So, I put up the stories kind of individually on Instagram, so you can go check that out, but obviously this compilation video is here so that you can go back and access that information at any time. So, when we talk about low sex drive, there are two main kind of subtypes in the realm of sexual medicine. The first is by far the most common, that is hypoactive sexual desire disorder, or HSDD. HSDD is characterized by a lack of spontaneous sexual thought or fantasy, a lack of erotic dreams, things like that. Patients with HSDD oftentimes will be able to experience enjoyable sexual activity, but they really don't have a desire to kind of go on and kind of initiate that themselves. A lot of times they'll feel like sex is more of an obligation towards their partner, or something they just have to kind of do. Now, remember, this is with any of the sexual dysfunctions, these are only issues if they are bothersome to you. If they are not, that's okay. You can have low drive or no drive or be whatever you want to be. That's not a big deal. This is only a problem if it bothers you and is affecting your quality of life. Now, the second type of sexual issue is what's called sexual aversion disorder, and I've actually made a video on that previously, so you can go check that out if you want to know kind of more details about it. Now, low sex drive is typically kind of thought of as something that is a result of an imbalance in what's called the biopsychosocial triad. And this is looking at kind of these three things. So our biology, our anatomy, how all kind of that is, hormonally, what's going on, psychology, kind of our emotional state at that time, how we feel about ourselves sexually, how we feel about sexual activity, and then the social aspect, and that's usually kind of either environmental factors like, stressors or things like that, or how we are relating to our partner at that time as well. And so if any of these things becomes problematic, it causes a disruption in that, and it will lead to low drive. Now, from a purely hormonal standpoint, especially in terms of the brain, which is by far the most common organ in terms of sexual desire, what we see a lot of times, especially in HSDD, is an imbalance between serotonin and dopamine. These are two neurotransmitters that your brain produces. Dopamine is an excitatory neurotransmitter. We release it when we do things we like to do, enjoyable activities, eating something nice, whatever it may be. And serotonin is an inhibitory neurotransmitter. We release it in terms when we're relaxed, we're chill, we're just kind of, hanging out. If you imagine your sex drive is like a car, serotonin is your brake, dopamine is your gas. And so, when you want to kind of get where you're going, you apply a little bit more gas. When you're already there, or you're kind of like, I don't really want to move right now. I don't want to go anyplace. You're going to put that brake on. So people who have HSDD, a lot of times it's like driving with the parking brake on. And so, you can get there, you can get the car moving, but it often takes quite a bit more effort to do so. You can still enjoy the drive, but, it may not be kind of the best overall experience. So kind of at the root of HSDD, specifically, that's kind of what's going on. Now, there are lots of factors that influence this, kind of like I mentioned with that biopsychosocial triad. And so you really also have to look at how this person is interacting with both themselves and with people around them and their sexual partner or partners. And so when I have patients that come in with low drive, I always ask about those things. Tell me about kind of your relationship. Do you have issues kind of with sexual desire to, do sexual activities with yourself, masturbation, self-stimulation, like that? Is it something you've always had? Is it something that's just been, new? There are a whole bunch of questions that can kind of filter in through this. But the big questions to ask yourself specifically with HSDD are, first of all, does your lack of sex drive bother you? Most importantly. The second is, can you remember a time when you had a, good sex drive? The third is, if you has this been something that's changed recently? The fourth, do you want to do something about it? If it is bothersome to you. And then you want to look at kind of other things in that as well. Are there other factors at play, other health conditions, dietary changes? Are your in-laws, sleeping in the room next to you or something like that? And so you put the whole picture together And that really gives you that sexual tapestry to see kind of what's going on. And you can see maybe where there's a run in that tapestry that may be causing the whole thing to start to unravel. So, when we look at treatments for sexual issues, for low sex drive, we've got a couple of different ways to go about doing it. As a physician, and not a psychiatrist, my first kind of line of treatment is thinking, is this something that I can treat with medication? There are currently two, count them two, FDA-approved medications for the treatment of hypoactive sexual desire disorder in premenopausal women. There is not an FDA-approved drug in postmenopausal women. That's a whole nother issue. But premenopause, postmenopause, you've heard me say it before, hormones don't care how old you are. Your brain doesn't care about that, how old you are. This is only a government kind of delineation, a delineation by the FDA, or Food and Drug Administration, for all of you non-Americans that may be watching. And with that, they're the ones that are saying, well, this can only be used in premenopausal and these are in postmenopausal. So, but really you can use them both. It doesn't matter. The two medications are Addy or flibanserin, which I've talked quite a bit about before. And the second is Vyleesi or bremelanotide. And I'll probably talk about that here in the future. I may try and team up with Tara Thompson again so we can go over that. Both of these medications work on those neurotransmitters. Addy is a serotonin agonist antagonist, meaning it kind of causes some serotonin receptors to be up-regulated or be filled. It kind of blocks other ones. Whereas bremelanotide or Vyleesi is a dopamine agonist. The melanocortin in there basically goes in and plugs those dopamine receptors. And this is great because you can use these medications synergistically and they work beautifully together. And so you have patients taking Addy every night to kind of increase their sexual receptivity. And then if they know, like, hey, this weekend we're going to go out on a date, they give themselves their Vyleesi, the afternoon of the date, and then they're ready to go that evening. So these work fabulous. I prescribe them quite a bit. I wholeheartedly recommend them. And if you want to know more about them specifically, I'm happy to answer any specific questions. Now, testosterone has often been prescribed for low sex drive. And you're right, in terms of sex hormones, it is definitely the one that is the most correlated with sex drive. But throwing testosterone at every single person that has low sex drive, honestly, will a lot of times not really help things. Like, it's something that you really have to look at and say, hey, does this person actually have low testosterone? If you give it to someone with high testosterone, you're just going to make things worse. Now, typically testosterone is prescribed in the form of either a cream or an injection. There are pellets you can use for it. There are also oral formulations. But really kind of the safest, most effective way to get a steady state of testosterone that's in the normal physiologic range, because remember, we're replacing this. We're kind of taking it back up to where it should be normally, is by a transdermal cream. Pellets and injections, you can get really big spikes and then they kind of start to fall. And, now you need another one. And so you have this big roller coaster type thing. Oral testosterone really doesn't absorb well. The stomach breaks it down pretty, quickly. Now, some people say, well, what about a troche or a dissolvable or a lozenge or things? And yes, that can work too, as it's getting right in your bloodstream, but that's talking about compounded medication. And obviously, I want to make sure that what I'm providing you is stuff that I feel I have an expertise in, and talking about kind of first line, standard of therapy. So there is definitely a place for compounding, 100%. I use compounding all the time, especially because there's not currently an FDA approved version of transdermal testosterone. So I always have to compound my testosterone. But like I said, I just don't really feel comfortable giving you an expert opinion on troches since I don't use them at all. Other medications that can work for sex drive, some medications like Wellbutrin or bupropion has been shown to, help with that. There are other antidepressants that have that may be beneficial. Some of the newer ones like Vibrid or Trintellix can be helpful. Also patients that have really high anxiety about sexual activity and they may feel really anxious about engaging in it, doing anti-anxiety medication may be helpful too. So there's a lot of different ways to go about looking at this. And this really points to the next step of helping low sex drive, and that's talking to a sexual therapist or a sex counselor. And the American Association of Sexuality Educators, Counselors, and Therapists, or ASEC, certifies these patients or people, practitioners. So if you're going to seek out a sex counselor, a sex therapist, find an AASECT certified sex therapist. Don't go, just random Joe Blow doing sex counseling. Like, find someone who's really certified in what they're doing and they know what they're doing. And they have a whole different way of looking at this and have a lot of different exercises you can do in terms of things like mindfulness, sensate focus, things so that you can really be present in that sexual situation. So the stressors of the day or what's going on aren't kind of playing around in your brain while you're trying to engage in that intimacy with your partner. So definitely AASECT certified therapist. And you can go on AASECT and find a list of those people. So that's great. Now, in terms of, other conditions that are affected by low sex drive, or maybe I should say other conditions that affect low sex drive, we have a couple of different ways of thinking about this. Now, the first is to look at it from a condition that's going to change the way we view about our sexual self. And remember, we all have these kind of masks we put on, there's these personas. Your sexual self is often one of your most vulnerable selves. You are displaying who you are without the covering of clothing or whatever for another person or people. And with that, if you feel that your body has betrayed you, if you feel that it doesn't look the way you should, things like that, that can really play into kind of low sex drive. And this is why we see low drive being the most common sexual complaint or concern in cancer survivors, because a lot of them feel their bodies betrayed them, especially, let's say, breast cancer survivors. Their breasts in our society are innately sexual, even though that we, use them for lactation and breastfeeding and things like that. The society still as a whole views them as a sexual organ. That's why you can't walk around with your shirt off if you're a woman. And so if you have those breasts removed, that can really impact how you feel about yourself sexually. Likewise, any type of gynecologic cancer, cervical cancers, anal cancers, things like that. A lot of times patients may feel very dirty. They may feel like, well, if I got HPV or I had an sexually transmitted infection, whatever it may be, I don't want to engage in sex because I feel gross about that. That makes me feel gross. The second subset, or let me back up with that too, also traumas, or like physical traumas. If you were injured in an accident, if you, have a surgery for something else and it causes a big scar, things like that, that can affect that too. The second category is going to be things that are kind of causing us to have pain. Conditions such as lichen sclerosis, endometriosis, interstitial cystitis, pelvic floor dysfunction. These all cause pain with stimulation of the pelvic musculature, which with penetrative sexual activity especially, that can do. You can get pain with orgasm with a lot of these conditions as well. And so the actual act of engaging in sexual activity, sorry, it's redundant, is painful. And we don't want to do stuff that hurts most of the time. At least not that we're controlling. You don't want to shut your hand in a door or slam a thumb on your finger because it's going to hurt. It's the same type of thing. You don't want to willingly engage in a sexual act that is going to cause pain because we innately don't want to feel pain. Now, masochism and things like that, that's a little bit of a different story. But for kind of this specifically, this causes a lot of low libido. So patients that have endometriosis or they have, lichen sclerosis, which honestly can affect that first category too, a lot of times. They may have low drive because not only do they feel that their genitalia may look abnormal or may have betrayed them, but it also hurts with stimulation. The third category is the kind of, I am doing this just for somebody else. I'm not getting anything out of this, obligatory type sex. And we see this a lot of times in couples who are in long-term relationships. And, in my practice, female partner may come in and say, I want to be a good wife, so I have sex with my husband when he wants to. I don't ever want it myself. I could care less. I'm sitting there just thinking about other things while it's going on, but he wants to do it, and so that's why I'm doing it. I don't get anything out of it. So that's going to cause low drive. Patients that have orgasmic dysfunction, they're not getting, that kind of orgasm, that release, after sexual activity. And if you're already taking a bunch of effort to engage in sexual activity, not getting anything out of it makes the act or the desire to do that even lower. You know, we are all inherently lazy. We don't want to do something if we're not going to get anything out of it, right? And so it's the same type of thing. So if you find that, you know, you're just engaging in obligatory intercourse, or like I said, you may want to have sex, but you know that it's gonna, you know, you're not gonna get anything and any type of enjoyment out of it. A lot of times libido can suffer from that too. So it really is very important to look at all of these things in a big picture. This is a very multimodal or multifactorial type approach to this. And so once you can see what's going on and you can pick those pieces together, then you can really kind of get to the root of the matter. And that's what sexual medicine is really all about. Remember, this is improving the quality of life for people. This is improving intimacy. This is making you feel like your best sexual self. Once again, this is only applicable if it bothers you. If it doesn't, that's okay. And we'll talk about that sometime in the future too. So anyway, I hope you've enjoyed this week's talk on low sex drive. As always, if you have any questions, don't hesitate to reach out. I'm Corey Babb, and I hope you have a wonderful rest of your week.